Hello and welcome to Healthcare Voices, where we bring you authentic voices behind healthcare innovation and impact. I'm your host, Katherine Cummings, former clinician turned technology advocate, and today I have the privilege of speaking with Dr. Koohian, an anesthesiologist at Kaiser Permanente. Dr. Koohian is going to be sharing with us some of the innovations happening in his field, as well as discussing patient safety and the steps being taken to improve patient outcomes during procedures. Thank you for joining us on the podcast today, Dr. Koohian. How are you?
I'm great. Thank you for having me. It's an honor to be on your show, and I'm excited to share some of my experiences with your listeners.
Thank you so much. Well, Dr. Koohian, I'd love for you to tell us a little bit about your background and what inspired you to pursue a career in medicine.
Yeah, so I was fortunate when I was 15 years old. I had the opportunity to shadow my step-grandfather in his family medicine clinic, and he had a mostly Latin-speaking patient population, and it was just an eye-opening experience for me. I got to walk through the clinic with him, and he was introducing me to his patients as a physician in training. And that moment really kind of solidified my trajectory. At that age, 15, I was still kind of malleable, so to speak, and I took that opportunity and I kind of ran with it. And ever since then, it's just been experience after experience that led me to the fortunate position I'm in now, which is working as an anesthesiologist.
That's great to hear. It's always nice to get started early and kind of know what your path is going to be early in life. Was there something in particular that led you down the career to anesthesiology?
You know, it was kind of a fortuitous circumstance, I guess. I was throughout medical school, I was planning to go into internal medicine, and I just happened to have an opportunity to rotate in anesthesiology, and a few of my friends had pushed me in that direction, just knowing my personality and what they thought I would do best with. And after working with the anesthesiology team at my medical school, St. Louis University, I really just became enamored with it. It was a perfect fit for my personality, and the more I saw, the more I liked it, and it just became a natural fit after that.
For the listeners who aren't sure what an anesthesiologist does and your role as a collaborative part of the care team, can you explain that to everyone?
Sure. So my little sister kind of put this best when she was introducing me to her friends. She says, "I'm the knockout doctor," but there's a lot more to it. And honestly, anesthesiology these days encompasses basically every part of the hospital. But I guess in terms of what most people expect from an anesthesiologist, we're kind of the captains of the perioperative ship. Uh, so if you imagine a surgeon books a case for surgery, that case shows up on our desk and we review it prior to the patient coming into the hospital. And then on the day of surgery, we're the ones who essentially take the patient from the preoperative through the intraoperative phase. And in the majority of circumstances, I'm one-on-one with my patients. So if you're having a knee replacement, I'm the one placing the spinal anesthetic, so to speak, and monitoring, taking care of the patient throughout surgery, and making sure that they do well in the recovery period. And then beyond just the intraoperative stuff, we do a lot of work in gastroenterology. For instance, yesterday I was in the GI lab. We had a busy day and lots of innovations and utilization happening there. We also work with interventional radiology, and labor and delivery is another one of our big kind of commitments, so to speak.
Prior to this podcast, you and I had a discussion around the shift in your field from paper charting to charting in the electronic health record. How has that shift impacted your practice and improved patient outcomes?
Yeah, so that's a really good question. I think when I started my training, this was back in 2016 at UC Irvine as an anesthesiology resident. Some of the locations that we worked at, some of the sites that we worked at were still using paper charts. And I really saw how difficult it was not only to keep track of a patient's health and vital signs during a surgery on a paper chart. But when, for instance, a bad outcome happened or you wanted to review why something may have gone wrong, it was really hard to go back and see what really happened in those moments in time. And fortunately, UC Irvine, while I was there, they shifted to the Epic medical system, and that electronic health record really opened the door for a lot of data capturing, minute to minute, almost second to second, vital sign recording, where if a bad outcome were to happen, we could go back and see exactly where a potential intervention could have been implemented. And it also allowed us to keep better track of our patients' health, basically health records. So any x-rays, any CT scans, echocardiograms, all of that information was readily available once we shifted to a completely electronic system. And I credit that with a big part of why anesthesiology and anesthesia care has become so safe these days. Just the ability to seamlessly record and share information with the other physicians taking care of a patient, making sure that we have a full picture of the patient before we take them into the operating room. Those are the really big highlights with the advent of electronic health records for our field.
Kind of along the same lines of safety, what are some of the processes you think could be improved to ensure better post-operative outcomes or post-procedural outcomes for patients? And are there any new technologies that really have come out in the last several years that can assist with that?
Yeah, so another really forward-thinking question. I really think that the best best thing for patients after surgery is being reminded, encouraged to not only take the medications as prescribed, but to follow activity recommendations. I think knee replacements are a good example. So if somebody goes in for a total knee arthroplasty or a knee replacement, it's really imperative that they follow with physical therapy, that they keep track of their steps, so to speak. So if you can encourage someone with a wearable device like the Apple Watch or any other analog device, you could essentially encourage them, remind them, hey, get up and walk, or get up and do some of those knee exercises. I think that is really one of those kind of human interactions that we can utilize healthcare technology for. The other thing you can imagine, I know you've had cardiologist Dr. German on your show before, and I really think that keeping track of blood pressure, vital signs at home, oxygenation is another field where you can really basically have a wearable device that you can monitor remotely. You don't have to keep a patient in the hospital necessarily, just have a system with an alarm system basically to keep track of what's happening after surgery. And that really could impact outcomes down the line.
I know that the wearable discussion has been something that we've talked about actually in all of the episodes. So it's really nice to hear that it's a continuing theme. Undergoing anesthesia, I think, can be really scary for some people. I know that I've had to undergo anesthesia for different procedures. And you kind of mentioned before how the role of electronic records has positively impacted maybe how patients might perceive and the safety of anesthesia. But how has the role of data and analytics assisted you in providing that safer patient care? And what would you share with a patient if you were talking to them about undergoing a procedure that required anesthesia that might make them feel a little bit more comfortable?
That's a great question. Yeah. So before surgery, I always have a discussion about individual risks and benefits with each of my patients. And while there's basically every organ system is taken into consideration, we eventually boil it down to what's called the ASA classification. So the American Society of Anesthesiologists, decades ago, they came out with this classification system so that we could easily convey patient risk, not only to other healthcare professionals, but to the patients, and be able to give them somewhat of an idea of what to expect in terms of risks and outcomes after anesthesia. And the biggest the most important driver of the safety in anesthesiology, I'd say in the last 40 years, has been the advent of pulse oximetry, which if you go back to the 1980s when that technology was first being developed, till now, it has made a remarkable difference in the safety of anesthesiology. It's just, it's kind of mind altering in a sense that we have a whole different set of goals now in terms of anesthesia. Survival is almost guaranteed, I'd say in the majority of situations. And now we're really focused on making the outcomes as good as possible. So, for instance, if somebody's going in and they have a history of atrial fibrillation, we want to do everything in our power to make sure that they don't have an intraoperative cerebral event. So no strokes, no heart attacks. We do everything in our power with the information that we have in real time to make sure that that patient has the best outcome. Part of that is just monitoring vital signs closely and continuously. And then if you imagine technology like pulse oximetry, arterial waveform analysis, all of that stuff is captured in real time and we're monitoring it in real time. That really makes a difference in outcomes. So that's data analysis on a minute-to-minute basis. But then on the bigger scale, you also have the larger anesthesia organizations, so the ASA, American Society of Anesthesiologists, and other organizations publishing research continuously about what the best way to take care of patients is, what vital sign targets we should have. For instance, during surgery, most anesthesiologists will maintain a mean arterial pressure of above 65 millimeters mercury. And that number was born out of, again, decades of research, multiple levels of randomized controlled trials, and all of it was feasible because of data capture and data entry that eventually gave us these recommendations to make sure patients did as good as possible. It's a big question. It's one of those things I could talk to you for hours about, but if I had to explain it to a patient, I'd say most patients, the ones who are the healthiest, ASA 1 or ASA 2 categories, I always tell them that anesthesia is about as safe as getting on a freeway in a car at any time during the day. And that kind of puts most people at ease, lets them know that, hey, this is as safe of a kind of healthcare intervention as possible. And the other big driver of that confidence is that malpractice insurance claims have gone down exponentially. Again, since the advent of oximetry in the 1990s till now, anesthesiologists are no longer the biggest utilizers of malpractice insurance, and our malpractice premiums have gone down because of that. And so if you ever want to find out what the real trends are, look at the insurance companies and see what they're doing, and that usually is a good way to find out.
That's really interesting to hear. I think pulse oximetry is something that we utilize in other fields of medicine as well. But along that same line, I understand that there is some electrophysiological monitoring other than pulse oximetry in neuromonitoring used during surgery, which is, I think, new-ish or newer. What is neuromonitoring, and how are you seeing this technology being used in your field more?
So, yeah, really exciting question for me because we just actually started our neurosurgery program at my hospital, and part of the safety of neurosurgery in modern times is electrophysiological monitoring, which the two biggest ones are motor evoked potentials and somatosensory evoked potentials. And even for myself, after years of studying the science behind these things, it's always confusing, and I like to simplify it even in my own day-to-day. So the motor evoked potentials, essentially you have a signal starting in the brain and being recorded in the periphery. So basically a electrical stimulus is delivered to the brain, and peripherally it's recorded to make sure that the patient has intact circuitry. So for instance, if a surgeon is working on the lumbar spine, doing a discectomy for a patient with lumbar radiculopathy or back pain requiring surgery, they want to make sure that in the course of their surgery, they don't cause any inadvertent damage to the circuitry and the connection between the spinal cord and the central nervous system and the periphery. So we monitor that. It's not actually the anesthesiologist monitoring in most cases. It's a specialist neurophysiologist who's there with us But we work together, we collaborate, and we're following in real time to make sure that our signals are strong. And if at any point a signal is lost, it's immediately conveyed to the surgeon. And whatever is putting pressure on the nerve, for instance, that pressure is we attempt to relieve it. If it's a medication response, so if one of the anesthetics we're delivering, it might be causing the decreased signal, but we'll change that as quickly as possible. And all of these interventions have led to significant improvements in outcomes for patients undergoing these complex brain and spine surgeries.
Are you seeing any neuromonitoring being utilized for obtaining information about the depth of anesthesia as well?
That's a really exciting question. So yes, that type of monitoring is frequently done by us. So your anesthesiologists and the other anesthesia providers in the healthcare continuum. We do have different measures. So one is called bispectral analysis, which is in short we call it BIS, BIS. It's essentially a crude EEG, so electroencephalogram that we monitor in real time, and it's really simple to place. It's a series of leads that go on the forehead, and they record brainwave activity in real time. And what it does is it takes a really complex signal. So EEG science takes years to master and learn, but we kind of boil it down to a number between 1 and 100. And one is basically zero brain activity or completely burst suppression or deep anesthesia. And 100 is wakefulness. And anywhere along that line, we can basically measure how our anesthetics are affecting brainwave activity in real time. And there's more research being done here as well in terms of, especially with elderly patients, how we can optimize the depth of anesthesia to not overdo it, which exposing someone to excessively deep anesthesia, especially in old age, can lead to increased confusion, delirium post-operatively, while also ensuring that patients don't suffer from intraoperative awareness. So that's one of the really terrible things that can happen to somebody under anesthesia is exposure to intraop awareness, and we really pride ourselves as anesthesiologists on minimizing that outcome with our current technology and our current methods. It's almost unheard of, honestly. In my practice, doing this for 7 years, I've never seen an episode of intraoperative awareness, thankfully, but I have heard of it happening, and it really comes down to being diligent, to being astute and observing the patient, but using technology to help us as well.
I love to hear that you're using a ton of different technology to make things safer and make sure that you're monitoring the patients really closely during their procedures. I know that a lot of clinicians are required to participate in continuing education to renew their licenses. But what about continuing education on technology? How do you stay up to date on the latest technologies and advancements in anesthesia to ensure not only your skills and knowledge stay current, but ensure that you're advocating for the usage of new technology in your practice?
I personally love using the ultrasound machine. It's a big part of what I do, and what I enjoy is using the ultrasound technologies that we have available to us to provide regional anesthesia, which essentially means using a machine to identify nerves, to visualize nerves, and give numbing medicine to a target nerve and numb an extremity. So let's say you're having a wrist surgery, you broke your wrist, you need a surgery to fix a wrist fracture. I can numb the whole arm for about 8 to 12 hours using an ultrasound machine. And the technology to get us there is relatively new. I mean, in the last 20 years, we've come a long way. And getting every anesthesiologist to up to date with that new technology, that new skill set, is something that I credit. Most academic departments will host events to teach their older anesthesiologists how to use these technologies. But then there's also conferences which encourage participation. And there's something called maintenance of certification for our specialty. And I really think it's at least a minimum requirement to be aware of the technologies and how to use them. But I'd say the majority of anesthesiologists are prideful about what they do, and they want to learn these new technologies as they're emerging. And so uh, physicians who are more skilled will oftentimes train other physicians who haven't had the opportunity to learn those skills and training. And I was really fortunate at UC Irvine, where I did my anesthesia training. They were very forward thinking. We had ultrasound training all throughout the 4 years I was there, and including my fellowship year. And I really came out of there feeling that I was prepared to do anything I needed to do with that technology. It's a good example. It's just one of many of how technology is kind of being taught and integrated into the specialty. But if you ask the majority of anesthesiologists in practice today, I think everybody has at least a fundamental understanding of ultrasound, and that really can impact patient care. Just the other day, we had a intraoperative event, and I used an ultrasound machine to visualize the heart and give real-time analysis to our team to make sure that our interventions were doing their job, and that to me was really gratifying.
That's great to hear that you're utilizing that type of technology. To pivot the conversation a little bit, I have been hearing a lot about augmented reality, virtual reality utilized in medical education. They're kind of buzzwords, right, in healthcare right now. Have you seen AR or VR play a role in healthcare education and training for anesthesia?
Yeah, it's funny you say that. When I was at UC Irvine, actually, during my fellowship year, one of my attendings, Dr. Navita Lem and I, we actually kind of built a research protocol to test virtual reality for procedures. So patients would come into our clinic. I was a pain management fellow, and some patients had anxiety, which was either a fear of needles or a fear of the procedure. And we randomized them to either receive the standard intervention, which is a benzodiazepine to help with their anxiety, or if they were interested, we'd enroll them in this virtual reality trial. And to be honest with you, the outcomes were positive, but it was a clunky system. It was a big headset. It only could be used if the patient was laying on their back. More difficult to use if they were laying face down, which is where the majority of pain procedures are done. And so we kind of ran into some issues logistically, but I think the technology itself has a lot of potential. And especially if you imagine a pediatric patient, so young children coming into the hospital, everything that they see is a source of stress. So seeing doctors and masks and nurses and needles, all these different things create kind of an immeasurable amount of stress on a young child. And using virtual reality is one of those modalities that we are starting to have at our disposal. We're still most of the time working with the iPads and watching Bluey or something on the iPad, but anything we can do to distract a kid during those stressful moments is helpful. And the larger pediatric academic centers do have published data and evidence suggesting that they can significantly improve outcomes for kids by using virtual reality. So I think those are the really big kind of avenues or arenas where they can be used. There's also some research in chronic pain regarding using virtual reality as a distractor for patients who have chronic pain, but it's kind of hard to capture that information. It's very subjective, and in general, it's an emerging science, but one that I think has potential overall.
Well, I have one last question for you, and this is a question I like to end the podcast with. What is one thing that you wish people knew about practicing medicine, or specifically about your field, or maybe one bit of knowledge that you'd like to impart on our listeners?
Of course, yeah. So I'll give you a little bit of my first off, my biggest advice for my patients, and anybody who's seen me in the hospital knows that I always go down this path in my discussions, is I always encourage people to be more active. If at any point during the healthcare experience I have the opportunity to ask people what they do for activity, and if they say nothing, I'm really lazy, I haven't done much, I always ask them, what's holding you back? What can we do to make you and help you get more active? Because that is by far the most important driver of good health, in my opinion. And that comes from not only the anesthesiology realm, but also in the pain management realm. People who commit themselves to being more active and getting back on their feet after whatever painful experience or whatever surgery they've had, they tend to do better and they tend to have better long-term outcomes. And so that's my takeaway. And I just want people to know that as anesthesiologists, people think that we are the knockout doctors. We're the ones who pass the gas, so to speak, and give them the relief from some of the stress and anxiety that comes with surgery. But I want them to know that we're also still physicians. We're doctors who went through medical training, and we care about their whole experience and their health as a whole. I really care about teaching as well, and I always teach my students, trainees, that even though we see the patients for just a window in time, the advice and the experience that we impart on them can change their outcomes long term. And I think that message has been well received, and I continue to try and share it with as many as I can.
That's a great final message. I really appreciate it. Dr. Koohian, thanks so much for being with us on the podcast today. We really appreciate you taking the time to share your expertise with us.
Thank you for having me. And I'm an excited listener. I'll be tuning in the future as well. Thank you.
Thank you to all of our listeners for joining us on the podcast today. We appreciate your support. To hear from more healthcare voices like Dr. Koohian, hit the subscribe button and share this podcast with your friends and family. I'm your host, Catherine Cummings, and you just listened to Healthcare Voices.